Right, thank you. And I'd also like to thank the organizers for inviting me to this really wonderful meeting. All right, so I'll try to speed it up to make up for the time lost here. So mantle cell lymphoma is not a common type of non-Hodgkin lymphoma. It's about only 6% of non-Hodgkin lymphomas. And if you do the calculations, there's less than 7,000 cases per year, which is less than Hodgkin lymphoma if you think about it. It's for practical purposes, we don't think of it as potentially curable disease. What I will summarize to you the current treatment strategies in acknowledging that there are options, and then keep in mind whenever we don't have a curable disease, there are different opinions and options. In the lack of randomized trials, these options all could be valuable, but I'll tell you at the end how I treat patients with mantle cell lymphoma myself. But the camps right now are divided between the RSC and non-RSC containing regimens for frontline therapy, and then the question, do we need transplant for patients after induction therapy, and that depends on the induction regimen. So when we talk about non-RSC containing regimens, these are the R-CHOP, the R-hyper-CVAD without the RSC methotrexate, the fludarabine-based regimen, and the bendamustine-based regimens. All these are being used or tested in frontline settings. And the RSC-containing regimen is the R-hyper-CVAD alternating with Rituxan methotrexate RSC. But also there's two other RSC-containing regimens. One, it's the R-maxi-CHOP with RSC with Rituxan followed by autologous transplant. And the second one is R-CHOP with R-DHAB followed by autologous stem cell transplant. Both were reported from Europe. So if you look at the outcome of patients treated with R-CHOP, this is the large cell lymphoma and mantle cell lymphoma. You can quickly tell that R-CHOP is not ideal for mantle cell lymphoma, whereas it's curative for at least 50% of patients with diffuse large B-cell lymphoma. So the question came then, how do we improve on R-CHOP regimen for patients with mantle cell lymphoma? So over the years, as I said, several regimens have been tested. Many of them are in non-randomized trials, straight phase 2 trials, knowing that the R-CHOP by itself is not a good option. So some people rationalize this, that it's not ethical to randomize against R-CHOP. I disagree with that, but that's what we have. So if you look at the R-hyper-CVAD regimen, which is alternating with R-methotrexate RSC, it's a classic RSC-containing regimen. It's more intense than R-CHOP. This is the data that's been updated by Dr. Romagera from our group, looking at failure-free survival and overall survival. And this is broken by age because of the autologous transplant candidacy using 65 years cutoff. If you are younger than 65 years of age, you do well, better than the older than 65 years of age, both in terms of progression-free survival and in terms of overall survival. Keep in mind that this is without transplant. This is a R-hyper-CVAD methotrexate RSC alone, without transplant. We use transplant only if you don't achieve a CR after 4 to 6 cycles. So if you achieve a CR, we just observe the patients, no maintenance either. Then the second regimen was reported a smaller number of patients from Brad Kahl using a modified R-hyper-CVAD. This is without the methotrexate and RSC, so the same first part of R-hyper-CVAD, but then they use Rituxan maintenance. Again, small number of patients, the progression-free survival is slightly worse than the RSC-containing regimen. Overall survival looked good, but the follow-up was short. I use this regimen for elderly people who can't tolerate the RSC-containing regimen, and I've used it in some of these patients. But in younger patients, I still use the R-hyper-CVAD with RSC regimen. So here to put this into perspective and for comparison, and I put in the middle the data that was reported by SWOG. Again, none of these are randomized studies. The first two use the identical regimen, the R-hyper-CVAD alternating with methotrexate RSC. This is a Brad Kahl program without the RSC methotrexate. Number of patients at 97 in the MD Anderson series, SWOG 47 patients, and Brad Kahl's only 22 patients. If you go down here at the CR rate, the CR rate was the highest with the RSC-containing regimen from Anderson Single Institution, was lower in the SWOG, and it's 64% with the Brad Kahl data. And if you look at median progression-free survival, again, it was slightly in favor of the RSC-containing regimen compared to the non-RSC-containing regimen. The other non-RSC containing regimens becoming popular, although there's really no large series, is the bendamustine-based regimen. Bendamustine plus rituximab was included in a large randomized trial that included both indolent lymphoma and mantle cell lymphoma. Few patients had the mantle cell lymphoma, which showed probably slightly better than R-CHOP in that trial. So now there's several phase 1 trials trying to build on that doublet by either adding dexamethasone, RSC, or lenalidomide. And these are the emerging data, at least from these combination strategies. Most of them focus on elderly patients and non-transplant candidates, these trials. But they're all like a small number of patients in a phase 1 setting. You can look at the CR rate, CR plus PR rate is high, with a CR rate increasing by adding a third compound to the doublet here, and up to 89% of patients, again, in the phase 1 setting. I use Rituxan bendamustine in a second line, and then occasionally I use it in front line in elderly patients. But again, there's really not much of data to show what's the progression-free survival in large number of patients with long-term follow-up. But it is an option in elderly patients, at least. So what is the best induction regimen pre-transplant? If you want a transplant patient, that was one of the questions that were asked in the beginning of this session. There are, as I said, 2 programs popularized in Europe. The MaxiChop from Norway. This is followed by Rituxan RSC plus autologous transplant, and then with preemptive rituximab. The European Mantle Cell Lymphoma Network reported the R-CHOP with RDHAB followed by autologous transplant. And the NCCN group did retrospective chart review comparing the R-hyper-CVAD with methotrexate RSC with and without transplant, comparing with R-CHOP plus transplant, and I'll briefly show you some of this data. So this is Nordic group trial. They compared 2 sequential trials. Again, this is not a randomized trial, 2 sequential trials. In the first one, they used MaxiChop with intensified CHOP, pre-rituximab era, but also used 4 cycles plus autologous transplant. And then the second one, they called it Mantle Cell Lymphoma 2 trial. Now they added rituximab, the same here, MaxiChop with rituximab again. And then they added the rituximab plus RSC, followed by the same autologous transplant. But again, after the transplant, they used what they call preemptive consolidation with rituximab for those who have re-emergence of minimal disease after autologous transplant. And by sequential comparison, in non-randomized fashion, they show that there's substantial improvement in the outcome when you look at the first-generation trial, pre-rituximab with no RSC, compared with the one with the RSC and rituximab. So they think that this is their own standard. They use the R-MaxiChop plus high-dose RSC rituximab autologous transplant in that setting. So here are again the 3 major approaches for comparison. This is the MD Anderson program with no transplant, and these are the 2 transplant-containing regimens, both from Europe. This is the MaxiChop from Nordic group, and this is the R-CHOP RDAP. Number of patients in the first 2 trials, 65-60, and then in MaxiChop, there were 160 patients treated. And then, as I said, in the first one, there's no autologous transplant. In the second one, there's autologous transplant. If you look at the end of this slide, at the CR rate, they had comparable CR rates, although the CR rate was slightly lower in the Giesler Nordic group program. And if you look at the median progression-free survival, they're really comparable. So the questions remains, do we really need autologous transplant after R-hyper-CVAD methotrexate RSC? From this data, one can conclude, again, these are not comparative data, that you probably don't need if you achieve a CR quickly with the R-hyper-CVAD, but clearly there will be need for a randomized trial to answer this question conclusively. As I said, in my practice, and most of us do the same thing, when we use R-hyper-CVAD methotrexate RSC, if the patient achieves a CR quickly, we do not usually routinely consolidate with autologous transplant. And to back this up, again, this is from the NCCN retrospective chart review. They looked at patients with mantle cell lymphoma treated with different regimens, R-CHOP plus autologous transplant, R-hyper-CVAD with no autologous transplant, and then they compared the R-hyper-CVAD with those who received R-CHOP plus transplant. To make a long story short, you can look at the p-values here, but you can look at these points here. What they found that the R-CHOP followed by transplant was better than R-CHOP alone. Again, this is retrospective chart review, so we don't know the denominator. They also find that if you treat patients with R-hyper-CVAD methotrexate RSC, the outcome is better than R-CHOP alone. But they also find if you do R-hyper-CVAD methotrexate RSC with no transplant, was as good as R-CHOP plus autologous transplant. The question remains, if we do R-hyper-CVAD plus transplant, is it better than R-hyper-CVAD alone? Again, no one knows the answer as of today. So this is the data from Julie Vose, also looked at retrospective chart reviews for patients referred to their center for transplant, and some of them received either R-CHOP or R-hyper-CVAD, either at their institution or outside their institution, and they're referred for transplant. And their conclusion from this comparative retrospective chart review that if you started with R-hyper-CVAD, the outcome is better than if you started with R-CHOP. But again, this is not a randomized trial. Give you some hints that maybe R-hyper-CVAD transplant is better, but it's not conclusive because it's not randomized. The next step, though, so to conclude this segment, there are different options for patients with mantle cell lymphoma as induction regimen, depending on the age. If they're transplant candidate, you can choose between R-hyper-CVAD methotrexate without transplant if you achieve a CR quickly. You can also use the transplant-containing regimens like the European do by using the R-maxi-CHOP or R-CHOP plus R-DAP followed by transplant. What about relapse patients? There are several new agents available. Two of them are approved, one in Europe and one in the US. In the US, Velcade or bortezomib has been approved based on a single-arm phase 2 trial, the Pinnacle trial, showing 32% response rate with a CR rate about 8% and a median duration of response of about 9.2 months. The European trial was based on a randomized trial that led to the approval of temsirolimus, an mTOR inhibitor. It was a 3-arm study using 2 different inductions program with temsirolimus versus investigator choice. The data showed that if you start with the induction of 175 milligram followed by the weekly schedule of 75 milligrams, you do better than the other 2 arms with 22% response rate and median duration of response of 7.1 months. Again, this is a curve of the higher dose of temsirolimus, which led to the approval of this agent, but knowing that the overall response rate was really low, only to 22%. But the 2 agents that's been mentioned before repeatedly by several speakers that are also generating some excitement in mantle cell lymphoma are the agents that target B-cell receptor signaling pathways and the PI3 kinase pathways. And these are not independent pathways because they crosstalk at several levels, including at BTK. BTK activation requires a PIP3 conversion from PIP2 through PI3 kinase. The signaling pathway has been explained again by several speakers before. Starts with Lyn, SYK, BTK, and then this leads to activation of 2 signaling pathways, NF-kappa B and ERK, but also there's activation of PI3 kinase through CD19 phosphorylation. There are several agents that can target this, and the one that went forward initially, the PI3 kinase delta inhibitor. And this is a summary slide showing data from mantle cell lymphoma, indolent lymphoma, and CLL using the CAL101 inhibitor, showing that the majority of patients responded regardless of the histology. The second agent presented in more detail by Michael Wang from our group earlier this afternoon is the drug that targets BTK, the PCI23765. And the initial phase 1 was reported by Ranjana Advani from Stanford, showing that, again, regardless of the histology, there's several patients who responded to this agent, including CLL, mantle cell, diffuse large follicular lymphomas, and others. And these are color-coded slides. And if you look in more details, if you zoom on the mantle cell lymphomas, there's 9 patients treated with the phase 1, and 7 of them responded. This really gave a signal that the agent may be active in this disease, and therefore a phase 2 trial was conducted, and it's ongoing international trial, but at least the interim analysis was reported by Michael Wang last ASH, showing that 69% of the patients responded and about 18% achieved a CR with single agent in the relapse setting, which is really remarkable. The trial is ongoing, and we'll need to hear the outcome after completion of this study. Finally, lenalidomide also has a single-agent activity across different histologies, including mantle cell lymphoma. Single-agent lenalidomide reported to have a 42% response rate. In comparison, rituximab has a 30% response rate in relapse setting. So lenalidomide is being combined with several agents, including dexamethasone and rituximab, in frontline relapse setting, and with some additive activity in this regard. And finally, the JAK-STAT pathway also has been shown to be active in several lymphoid malignancies, including mantle cell lymphoma. We reported the results of a phase 1 trial using the oral JAK2 inhibitor SB1518. Again, this is a phase 1, which includes several histologies. If you can look at the mantle cell lymphoma, these are the yellow bars here. Several of them have responded to this agent. The phase 2 has not been reported yet using this inhibitor. So to put all this into perspective, there are several pathway inhibitors. I think the PI3 kinase pathway inhibitor and the B-cell receptor inhibitors are leading now within the single-agent activities. These inhibitors have activity across different histologies. So if you look at the PI3 kinase pathway, both everolimus and temsirolimus that target the mTOR component have a response rate in the 30% range. CAL-101 has 67% response rate, which target PI3 kinase. And within the B-cell receptor signaling pathway, there's 2 agents being tested. The first one was the SYK inhibitor, had only about 10% response rate. But if you target a downstream component, which is the BTK by the PCI compound, the response rate is 69%. This is actually surprising because you would think that if you target an upstream molecule, you should have a higher response rate. And here it's lower. That suggests that probably the BTK inhibitor has some favorable off-target effect. So in conclusion, the question of this that was raised by the title of this talk, are there agents improving the survival of patients with mantle cell lymphoma? The answer is yes. This is an outdated slide looking at improvement in survival over the last decade. And I think if you now look at the outcome of patients treated within the last 5 years or so, you expect to see the overall survival even better than this. Last count from Cornell was about 7 years, and I think many of us have patients who live 10 years and more or longer with mantle cell lymphomas. So in conclusion, I think the overall survival of patients with mantle cell lymphoma continues to improve. There are several new agents demonstrating favorable outcome in phase 2 setting. Randomized trials will be needed, of course. We need predictive biomarkers to start selecting patients, and we need to start combining these agents in rationally designed trials. And thank you.